Thank you, Dr. Rema. Chief Consultant, Eye Care Center, IZOL, for giving me opportunity to express my sincere thanks and gratitude on the occasion of the 20th anniversary celebration of Eye Care Center, IZOL. I feel privileged to be here to deliver a short speech. My speech will be really short. It would be a wonderful memory for Eye Care Chief Consultant Dr. Rema and his team that how the center has been improved so much in the year 20 years to attain this present prestigious height. The Eye Care has been known for its marvelous voluntary work for the community in terms of eye care, as the name indicates. Chief Consultant Dr. Rema is a fine and experienced eye specialist who serves the government of Mizoram till his superannuation without being reprehended. Rather, he accomplished duty with exemplary. His team has conducted many eye camps in different parts of Mizoram. Thereby, a lot of community benefited. This center regularly observes World Sight Day every year with much enthusiasm. That's so that there is a wide range of consideration for the eye. Usually the eye program and eye camp they have so far done in the different part of Mizoram, usually followed by the eye clinic, where so many people avail the clinic to their credit. The Eye Care Center is exemplary in many ways, and they set example for the people of Mizoram, especially in the coordination with the Healthcare Society of Mizoram in giving away and in carrying out the healthcare scheme like ABPMJ Way and Mizoram State Healthcare Scheme, so that a lot of people benefited from this scheme. The Eye Care Center saw an example in many ways. So they are one of the few who joined the healthcare scheme in Mizoram. So they are really far runner and exemplary to other private hospital and NGO hospital also. I hope all of us will be benefited in this time also. And in connection with this celebration of the 20th anniversary of Eye Care Center, we are fortunate that it has been followed by this clinical session so that we can refresh our knowledge. And I am very pleased that a lot of experienced and popular and expert people from Northeast India, from Calcutta, from Guwahati, and from Silchar, who are going to share their experience to our here local people, so that we can be more up to date in our day-to-day work. Thank you so much. Thank you.
Principal Director Dr. Evelyn Lira, thank you for your message and brief encouragement. So here our audiences, even though are few, but people are very interested in eye subject, and we are gathered together here from Civil Hospital, Aizawl, Durklang, Eye Department, Ripans, and Zoram Medical College and from Eye Care Center. So once again, I welcome you all. So we are coming to our next session. CME program is very, very important, as well as for the time of speaking medical ethics at this time. Without saying this, we cannot score the point for this scientific session. So may I request Dr. Ma Lalhuthanimar to speak about the medical ethics.
Good evening, everyone. First of all, I would like to say a few words regarding the 20th anniversary celebration of Eye Care Center. Dr. Rema has been my guardian, my best friend, and he has been always there for me whenever I need any help, any advice, and I'm always in debt. Sir, thank you so much for guiding me throughout the years in our service together, serving the government and the state. And I would like to congratulate Eye Care Center for achieving a wonderful achievement. It has been the leader. Sir has been the leader in every field of ophthalmology in Mizoram. Thank you so much, sir. And tonight, I'm very thankful for Dr. Remsanga to give me this opportunity to talk about medical ethics. So we'll talk about a few points about medical ethics. So Dr. R.C. Pal may be wondering why I'm talking about medical ethics, not about ophthalmology. Since I'm one of the OB, office bearers of Indian Medical Association of Mizoram State Branch, I used to talk a little bit about medical ethics. What exactly is ethics? The study of morality, careful and systematic reflection on and analysis of moral decisions and behavior. What is medical ethics? It is a code of conduct for members of the medical profession in their interactions with others, their patients, and the state. It's a very, very important topic. So why should we study medical ethics? It is since it's closely related to law. In most countries, there are laws that specify how physicians are required to deal with ethical issues in patients' care. Often, ethics prescribes higher standard of behavior than does the law. The basis of medical ethics is based on the concepts of professional morality which are prevalent in the medical community. Such moral concepts can vary with time, hence ethics too can change with time. So law versus ethics. The law deals with undesirable medical practices. Ethics deals with undesirable medical practices. Then law is created outside the medical profession, whereas ethics is formulated and imposed by the medical community. Then the law does not cover all aspects of medicine, but ethics covers medicine extensively. Then the law is centered around justice for all citizens, whereas the ethics is centered around patient welfare. In law, an illegal act is not always unethical, but in ethics, an unethical act is not always illegal. And in law, there is trial and punishment for illegal acts by the court. Then in ethics, trial and punishment for unethical acts is done by the State Medical Council. Then punishment is by fines and imprisonment in law, whereas in ethics, it is by warning or removal of registration. What is so special about medicine? Throughout almost all of recorded history and in virtually every part of the world, being a physician has meant something special. We are special, no? We are very, very special. The status of physician differs from one country to another. Then many physicians feel that they no longer are respected as they once were. I think we too, even though we are not yet very old, we feel this, I think so, in this modern world. And control of healthcare has moved steadily away from physicians to professional managers and bureaucrats, some of whom tend to see physicians as obstacles to rather than partners in healthcare reforms. Then patients by patients on diagnosis. Then entry of medical technicians, nurses, paramedics. Nowadays we fight this NMC, no? So now we have, what is that, community health workers. Now we are fighting the government, the Indian government, to remove this, not to impose this NMC, because there will be cross-pathies, so many things, bridge course and all. And recently also, I think within a few days also, we'll be having another strike or some protest against this NMC, because it's still there, that cross-pathy and bridge course is still there, it's still alive. Though they said that it will not be imposed, but it's still there. I think we still have to fight about this one. Then physicians and patients. The physician-patient relationship is the cornerstone of medical practice and therefore of medical ethics. The health of my patient will be my first consideration. This is in the Declaration of Geneva. A physician shall owe his/her patients complete loyalty and all the scientific resources available to him or her ICMA. Then respect and equal treatment, not to permit consideration of age, disease and disability, creed, ethnic origin, gender, nationality, political affiliation, race, sexual orientation, social standing or any other factor to intervene between my duty and my patient. This is in the Declaration of Geneva. Then we have also the right to refuse a patient. We physicians have the right to refuse a patient. Then termination of patient relationship. Then persons with afflicted with HIV/AIDS. And compassion is one of the core values of medicine and is an essential element of good therapeutic relationship. Compassion is based on respect for the patient's dignity and values, but goes further in acknowledging and responding to the patient's vulnerability in the face of illness and or disability. If the patient sends the physician's compassion, they will be more likely to trust the physician to act in their best interest, and this trust can contribute to the healing process. This is very, very true. Then regarding communication and consent, informed consent is one of the central concepts of present-day medical ethics. Then the right of the patient to make decisions about their health care. All the patients have the right to choose to make decisions about their health care, to choose what type of treatment they want. And good communication skills do not come naturally to most people. They must be developed and maintained with conscious effort and periodic review. Confidentiality, we have to maintain confidentiality throughout our practice as a physician. The Hippocratic Oath states, "What I may see or hear in the course of the treatment or even outside of the treatment in regard to the life of man, which on no account one must spread abroad, I will keep to myself, holding such things shameful to be spoken about." Then in International Code of Medical Ethics, it states that it is ethical to disclose confidential information when the patient consents to it, or when there is a real and imminent threat of harm to the patient and to others, and this threat can be only removed by a breach of confidentiality. Then beginning of life issues like contraception, assisted reproduction, prenatal genetic screening and abortion. And end of life issue, euthanasia, the act of deliberately ending the life of a patient, even at the patient's own request or at the request of close relatives, is still considered unethical. This does not prevent the physician from respecting the desire of a patient to allow the natural process of death to follow its course in the terminal phase of sickness. And physician with our colleagues. So the physicians belong to a profession that has traditionally functioned in an extremely hierarchical fashion. With the rapid growth in the scientific knowledge and its clinical applications, medicine has become increasingly complex. So individual physicians cannot possibly be experts in all their patients' diseases and potential treatment, and they need the assistance of other specialists, physicians, and skilled health professionals such as nurses, pharmacists, physiotherapists, laboratory technicians, social workers, and many others. So we need to know how to access the relevant skills that their patients required and that they themselves lacked. This we know it very well. Now a cooperative model of decision making has replaced the authoritarian model that has characteristic of traditional medical paternalism. Then other healthcare providers are increasingly unwilling to follow physicians' orders without knowing the reasons behind the orders. Doctors to doctors. So our doctors to doctors, this is very, very important, our relationship between one doctor to another. We should not entice patients away from a colleague. And when consulted about a patient, offer an opinion, but do not take over the case unless asked to do so. But I think most of us are unethical about this. I think so. I believe so. When referring a patient, provide all relevant medical information to the concerned doctor. Then reporting of unsafe or unethical practices. This is a very, very touchy issue. That's all. Thank you so much.
Thank you so much, Dr. Mar. Now I call upon Dr. R.C. Pal to speak about the management of presbyopia with multifocal IOL. Dr. Mar, you are so correct in bringing out the ethics issue. Particularly, there are so many young aspirants of medical science here. You always remember all the young aspirants. You always remember that medical ethics is something beyond law. Like law has made so many reservations and so many rights to religion, but only your belief can make belief in God or belief in Allah or belief in Ishwar can make you religious. Similarly, ethics is just like that. We are in a profession, we are businessmen like any other businessman in the market. But we are in a business where the customer pays and gives you a pranam. That is the greatness of our profession, where the customer pays and gives the pranam, not the businessman. And she was very correct that we should have a holistic approach of the disease. A disease complex is made of three things. One is the physical problem, that is around 40% of the disease complex. Second one is mental agony, which is about 50%, and 10% is economic problem. So if we take care of the diagnosis, we are taking only 40% care. And if we take care with a smile and compassion, we are taking 90% care. And if we are considerate in giving the prescription, we are taking 100% patient care. That is called total patient care. Thank you. Dr. R.C., please.
Thank you. Good evening. So, nice gathering. So the intention of this talk for few minutes will be on what is happening in case of presbyopic IUL. So if I take, this is a very simple case of cataract. Nothing more to highlight onto this, making an axis of the optimal size so that the IOL is anchored 360-degree wrapped in the margin. So this is one of the difference. Probably sometimes we compromise in other IOLs, but here we do not. Then simply removing the cataract. I think light is okay. We can see. So that makes no difference. We need a little bit meticulous cleaning because this kind of patient cannot afford a PCO. Here is a little modification. Give sufficient time if you are using these new trifocals so that it quietly unfolds. Make it center. While you are completing, you can see it is enlarged. There are two foci, one by the microscope and light, another is the Purkinje image with the IOL center, and you close the eye in such a fashion that it is not very soft or it is not very hard, so that the IOL doesn't rotate. These are like normal post-op. But what is the scope of it? If we really go on putting any kind of patient, this is an Asian study which shows us you can test in your own patient. Around 69% of the patient they desire, after the cataract surgery, that they require all distances vision, means starting from very near to indefinite distance. Can you put this light on so that I can see the faces? So what basically the objective is basically here in case of presbyopic IOL, just those who are using glasses, maybe an addition to the near, intermediate or any distance, and here to maintain the existing whatever the technology, the typical design characteristics, manufacturing process, and which doesn't impart any visual disturbances after putting this IOL. So currently, what are the options we do have? One eye is for near, another eye for the. We just last light. We don't need that much of light here. So let it be there, no issue. Just put some lights. I can see. Oh. So make it.
This light is little affecting the view.
Okay, sir. Thank you.
But that side you keep because speaker want to see their vision.
So I don't mind if you have any query in between. So what is the current designs are there is basically one eye is for the distance, another for the near or any distance or kind of bifocal segment starting from addition from +1 to going for +3, different technologies, diffractive, refractive, and definitely the EDOF means having a line focus instead of a point focus, and off late is the trifocal, these progressive lenses we are using for last few years, and we are very happy. So what basically in this design they have intended? They intended with the existing bifocal segment to add on something, an intermediate distance. This is number one. And to provide excellent quality of vision in all the ranges, and utilize the expertise of the back years to manufacture process this kind of technology. So this is a fancy name, like Alcon peoples are very fancy putting, this infinity system, Centurion system, the IQ, IUL, etc. And this what is called intelligent FECO. So this is again another name, fancy name, enlightened. But what does it mean is actually to how really the more light can be passed through the IUL into the retina can be sensitized. This is the number one. And number two, the different segments from where the different ads can be added on. So practically it works. And thirdly is the intent on, we understand in the different light conditions, we have different pupillary size. So it should be pupil independent. So roughly here they put at an, the optical part of 4.5 millimeters. So whether you are going to very, dim light or strong light, so it is pupil independent. So this is the intent of putting it. But more interestingly, what they did, we here in the Indians, we are not very, tall people. So whenever we held any gadgets, is very not that very distance, not that very close. So a study has been made that in case of these Asian peoples, this distance really, when we check like ma'am this cell phone, see she is holding at 60 centimeter distance. So whatever in the available computer brains, this is an 80 centimeter distance. So that makes a major difference. You can try yourselves when we can, with an arm length, we put something. So to give an intermediate focus at the 60 centimeter, not with the existing what other computers have at the 80 centimeter. And of course, an good near at 40 centimeter, 30 to 40 centimeter. Here they focus something higher to 40. So if you compare with the Alcon PanOptix with the Zeiss, this is also very good lens, but what makes this difference that the intermediate distance at the 80 centimeter, which is not very comfortable for us. The Physiol is another company, the same part it is at the 80 centimeter. Symphony is very popular, but of late the market has gone down because those who are using, we know the patients have, we have to keep the patient myopic. Still patients are not very happy about the very near vision. Sometimes they demand some +1 or +1.5. Otherwise, else it was a very good lens. So if I go on summary, the trifocal is one of the best presbyopic IUL. So here I am going to, I believe iCare is also in future. One day I will be coming over here if I am alive to having this femto laser cataract surgery. That has certain advantage, but one of the greatest advantage probably in case of presbyopic IUL. Why? It is not only for safely removing this cataract, this centering and the exact, the CCC what we do get, that keeps the IUL centrally for throughout the career. So we have an opportunity, or we are privileged to have this access into this technology. It's very simple, same, nothing great, but little bit expensive. But when the people's, so here this is the beauty. You can see in the IUL there are 21 diopter, then 2.2 diopter, then 3.2. So in the IUL plane, if it is 3 and 2, so you can calculate in the optical plane whatever there. So that gives you into 40 centimeter, 60 centimeter, and definitely the far distance, whatever the focus we do say. So here IUL is not folded very well. It's for demonstration. So but it is normal. You have to twist the IUL little bit, but really that gives an advantage if you have access to. But exactly what our apprehension is. If this is so good, what prevents us? Certain issues are definitely there. This is some apprehension that I am taking more money because the company won't give me in very cheap price. Maybe they will give initial 1 or 2, but when they find they will charge whichever company, they will charge high. So there is a question of reputation loss. There is apprehension that my patients are very happy with the specs, so why to take extra risk if the patient somehow is very unhappy. So certain things I will be going to share you with today, which makes the happy life of the surgeon and the patient, of course. And if there be any intraoperative problem like general dialysis, PCTR, etc., how I will manage the patient after that, because I have asked the patient that you will be seeing in all distance from next day, and now I would not been able to put an implant, even had to go out for a 3-piece IOL. So these questions are there into my mind. So this is, we call it fear factor. So there should not be any fear factor. So if we go on, this is very scientific, very important for me, how do we analyze? In case of this presbyopic IOL, first we do start, this is a flow chart. So this is a dry eye that had to be eliminated. Why? Because in the post-op, number one, the patient won't be happy, and second of whatever the calculations we are going to take, that won't come correct. Even your biometry, the keratometry, everything will go wrong. So first you have to eliminate this dry eye. Then probably the corneal surface, if it is regular or irregular. If it is regular, fine. If it is astigmatic, you can put, sir will be talking on toric. So the trifocal toric or the bifocal toric, mostly nowadays we will suggest, trifocal toric. Else if it is an irregular cornea, so you have to treat, you have to send to people like Dr. Sudeep Chaudhary that what are the things, how to go for solution. That lens is not the area, but this is very important in case of this group of, these patients. This is very important, this keratosis, the main port. It is not underhydrated, it is not overhydrated. So this is again an important slide for me. So what we do say, now we have so many options, right, from the different companies. You have EDOF, you have somebody will come, sir, the near edition is +3, this is beautiful, that has this advantage, that advantage, all these things. But what we do say, when the patient come to us, really we sit with this score sheet. We say nothing is complication free, everything has some complication. Suppose a very old lady comes to me and say, I was in college professor, I can't go inside, outside too much. I really love to have reading. I don't hesitate to put even in bifocal the restored +3.5, which has lots of criticism, because these people are really very happy people, with the +3.5 bifocal. The near edge is so beautiful. If someone comes to me, a very youngster from the IT of 45-50, he says, I want to, need both, sport, outdoor sports, and lots of, the apps activities, either in the phone or in the segment. I say best you go for an, this trifocal design, trifocal. Earlier it was, of course, Symphony. I don't hesitate to mind, so I just used to keep them little bit myopic. It was in compromisations, but nowadays after this trifocal, and especially this Alcon Panoptix trifocal, yet I had to find a single patient still that unhappy. Most important part is, this preoperative counseling and the patient intentions to having this kind of IUL. In conclusion, I must say this is a wonderful presbyopic solutions in today's era. Only condition is this: if we have really a good counseling and preoperative proper selection, and maybe a normal biometry machine will do, a normal keratometer will do, but you have to be really meticulous. You have to exclude, these dry eye symptoms, the irregular corneal astigmatism, these nerve disease patients, glaucomas, diabetic retinopathy, RMD, whatever the things in the posterior segment. So that achieves, that rocks. So thank you, and very nice evening for giving me this opportunity to sharing this experience. Thank you.
Thank you, Ruth. That is.
Good evening once again. After the heavy dinner, it is really a punishment for you to get into this phenomenon. More so, after a brilliant talk by very dear Arsipal, I am even embarrassed to bore you. Although I have written astigmatism management with toric IOL, in the print I find understanding astigmatism with toric IOL. I like it because my idea and my point is, if you are going for a toric IOL, you must understand astigmatism. And for the beginner, I will definitely dare to ask you to read the astigmatism chapter very nicely. although we have taught you in undergraduate and postgraduate courses. But once you specialize in ophthalmology, you rarely study astigmatism. Therefore, you must know every details of astigmatism. With the rule, against the rule, irregular astigmatism, as Dr. Paul was telling, irregular cornea, everything. Steep axis, flat axis. Because many ophthalmologists, before starting toric IOL, do not go into the details of this, and they get confused. Sometimes they depend on their optometrist, sometimes they depend on Alcon people. So it is good. I'm thankful to Alcon people, but because they help us always, no doubt about it. But this is my suggestion. Before you start, you must understand astigmatism. My second point is, before you venture into toric IOL, you must be convinced that you are doing a good thing for your patient. Unless you are convinced, you cannot convince your patient. Therefore, be sure that you are convinced you are doing a good thing for your patient. Then definitely, with that open heart, you can convince your patient that you can do counseling, as Pal sir was telling. Before you counsel, your mind must be clear that for heaven's sake, I am doing something good for my patient. Now, for successful outcome, my job was reasonably completed by Dr. Pal, because good patient selection is very important. Good patient selection is very important. And while selecting the patient, you will find two types of patient. One type of patient are aware of their astigmatism. They are, if you go into their medical file, they have cylindrical spectacle. So always look for their medical file and see their glass. I always instruct my optometrist to write what is their present glass and if there is any past history. So a group of patients, qualified, educated, they know that they have got astigmatism. So for them you can counsel better, because they know what is astigmatism. So you can tell brother or sister, you have got cataract, at the same time you know you have got astigmatism. And here is a scope with toric IOL, we can correct your cataract and at the same time we can correct your astigmatism. So why bother using cylindrical lenses after cataract surgery? They will be happy. They will be happy. But one thing is again there, that wow factor will not come, because they are having 6/6 vision with cylindrical correction. The other group is who have never been corrected cylindrical, they have got astigmatism. I have seen even my some colleagues, doctors, having astigmatism, never corrected their astigmatism, and they are happy go guy. And in fact, stupidly, I was of the impression that if the person is having enjoyable life with astigmatism for 60, 70 years, why on earth give them a toric IOL costing so high? But I am convinced now, after attending so many CMEs, thanks to IOL people, they have also taken me to so many higher technical, training centers. Now I am convinced that if you correct astigmatism to a person who never had astigmatism correction with spectacle, he will get wow factor. He will tell his grandchildren, during my early childhood, my vision was not so good. After Chaudhury's surgery, I can see even better. So that wow factor will be there. But it is difficult to convince them because they never had spectacle correction with cylinder. Follow my point, no? Am I on the right track? So preoperative workup, Dr. Pal has said, that is very important. Preoperative workup, it is no matter what machine you are using. Sincerity and the quality of the person who is doing your work. For long I used to do myself because I did not believe anybody. But over the time I found it is impossible to do everything in one hand. So you have to train your people. and you have to train. It is not how qualified is your person, how sincere is your person, that is most important. IOL calculation, of course, you have to do correct, and good surgery with well-centered IOL is again a very important point. Now, regular astigmatism, that is why I say you must learn astigmatism first. Because what is regular astigmatism, what is with the rule, what is against the rule, what is steep, what is flat, everything you must know. You cannot just depend on a paper coming from Elcon company or from internet and then put it on the chest of the patient and then do. No, not like that. You must know the subject. Now, for beginner, maybe 1 or 1.5 to 3 or 3.5 astigmatism should be ideal, I think, for the beginner. And of course, if the patient is not like that lady about whom Dr. Pal told, who is happy only reading, about the younger generation, like to see cricket game and then do driving, this and that. That means that dependence on glass for distance should not be there. Patient should be happy-go guy. So select those cases and they will be happy after your surgery. Now, exclusion criteria, some of the things our friend has already enumerated: irregular astigmatism, post-refractive surgery, any defect, major defect in cornea, corneal dystrophy, corneal edema, and of course, very clearly our expert has said if there is problem encountered during surgery, maybe piscirant or genular dialysis, or maybe damage to our Chaudhary sir is doing premier IOL, not other people are doing in this area like that also. So without much. So this is a very good thing he has started in Silchar for the first time. Like that, toric IOL is very good. And then you have got astigmatism because the optometrist will do first, he will detect, keratometry he will do, and then he can just put little bit in the ear. And then the counselor will tell in another ear, little bit. And by the time he reach my room, he is already mentally prepared for something to hear from the big boss. And then once, I say, he will always agree. Yes, sir, whatever you say is final. It ought to be. Preoperative workup, see, refraction, keratometry, and then surgically induced astigmatism. Regarding surgically induced astigmatism, means what is your average astigmatism? There is a thumb rule that is there, but it is always good to find out your own. Doing 30 to 50 case, you can find out your own surgically induced astigmatism, biometry and marking technique. I'll come one by one. Now, regarding keratometry, manual keratometry, IOL master is no doubt okay, fine, costly, but manual keratometry is equally good. Autoke, we always, compare biometry, manual keratometry with autoke. Corneal topography, of course, I don't have, and combination of at least 2 techniques should be there. But at the end of the day, as Pulsar has also said, a well done manual keratometry is always probably still the gold standard. Now, surgeon specific criteria, total astigmatism should include SIA. SIA will be calculated from the, that drhill.com, but by thumb's rule, depending on the size of the incision, I do 2.2 always, 2.2 always, but if it is less than 2.5, it is about 0.5. I have calculated mine, which is even less than 0.5, about 0.3, about 0.3. But if your incision is bigger, the thumb's rule is 0.7. You should calculate as SIA. Axial length measurement, IOL master, lens star are ideal. Not all can afford always, but immersion technique for direct contact with immersion technique is equally good. They say it is almost as good as axial biometry. An online toric calculator, as I said, You can do it yourself, or you can take help from Prabhat or from anybody. Now this is a very important for online toric calculation. You have to set surgeon's name, patient's name, and then what you want to do, what you want to give is axial length, then anterior chamber depth, and then flat K, stiff K, and from this and the desired IOL power. From that you can find out the toric calculator. Now toric calculator, another very important point is the incision location. Incision location, for me it is constant, 110. For me it is constant. Now it is the headache of calculator to find out with 110 what should be the type of IOL and what should be the astigmatism and where I should set. This is very simple, nothing to worry. You can decide where you want to give incision. Temporal I don't like. I don't want to bring this controversy here because this is not the view. I am working on this point. Sometimes I will tell. I will just say only one small thing, that I have been working on this, that the angle of the anterior chamber temporally is smaller than superiorly. That I have found out. I will come out with some publication after some time. Therefore, those who are doing regular temporal, I am against them. Now, regarding marking technique again, accurate marking is very important. This bubble marker, I tried, but in ophthalmology, this is one of the toughest things that I found. Ophthalmology is not easy subject, many things are difficult. But this bubble marker, I must tell you honestly, because in bubble marker, there are two things. One, there is a bubble. Another is marker. So your one eye must look into the marker, and other eye must look into the bubble. For me, both eye work together. They cannot separately work. So when I look into the bubble, the marker is not on spot. And when I look into the marker, bubble is gone away from the center. So, honestly telling, I rejected it. Then I purchased Joja. This is, innovated by some doctor from West Bengal. Bhaskar Rai Chaudhary. A genius. Bhaskar is a genius. I like it, but there are some problems. This is very simple. This is the one. This is the one where you put the slit according to you fit it on the slit length. This is the marker or what? Pointer. Center. Huh? Yes, sir. So you put coaxially this one, and then you find out which axis you want, and then you take the light slit according to your, then you remove this one and then put the patient. So this is also little cumbersome, but better than bubble marker, no doubt about it. I have used number of cases. This one, this cost 25,000, not easy, 25,000. So what happened? You have to put it, and then after fixing your axis, you remove it and then put the patient again and then do your job. So I have found out an easy way. I have, used the slit lamp as the marker. So in the slit lamp, you can see, you put all the markings and then put the patient with the slit lamp marker on, and you can just put the slit accordingly. So no need of opening this one, putting this one and removing this one. So that is the easiest thing that you can do. This is of course, that traditional first way, that bubble marker, you put this through. And these were the instruments which I found very cumbersome and I never liked. And this is of course, I cannot say I don't like, but this is the domain of the richest of rich surgeons. So if time permits, I will request Dr. Paul to say something about this one, because I cannot afford. Now, fecal emulsification, as I said, what I do is 2.2 clear corneal at 110 degree, and always I try well-centered CCC with 360 degree overlap. CCC Rexis I do around 5, but as it is manual, it is estimated, it may be little less or little more, but try 5. Now, when you put the IOL, marking is already there, and the marking that I do remains for 7 days, not to speak of going away on the table, so no problem. Now, while injecting the lens, I always try to put it little less, so about 20 to 30 degree, because if you put it exactly at the mark, it will go the other way, and then you have to rotate it again 360 degree. So after putting it, you have to remove the viscoelastic very nicely. Removing viscoelastic 100% is impossible. No one can do, but you must try as maximum as possible, because if viscoelastic remains behind the optics, chance of rotation is fair, and if you can remove maximum amount of viscoelastic, then the lenses, particularly Elcon lenses, of course AMO lenses are also good, the quality is that if you gently tap it, it usually remains there. Rarely it rotates, unless there is shallow anterior chamber or something, which generally do not happen in 2.2 phacosurgery. Now, what you do IOL alignment, as I tell, just you put it gross 20 to 30 degree short, then remove all OBD, then you do final alignment. But it has happened in my hand. If while trying to be too correct, there is one saying, too good is not good. In Bengali, beshi bhalo bhalo na. Like that we say. So too good is not good. If you try to be 100% correct, generally you will cross the limit. And then you are in trouble. Again you have to rotate. And not all surgeons like Rotish Dada can rotate so easily. Sometimes for beginner, maybe you have to give viscoelastic again. Otherwise, of course, if you put a irrigating channel from the side port, you can rotate. Otherwise, if you try forcibly, the posterior capsule may be damaged. So therefore, but one thing is sure, if you have gone beyond, you have to rotate it again and bring into the correct position. Now, post-operative, next day, I really don't dilate. If the patient is happy, I keep it. Generally, the surprise has not happened yet. But after 7 days, I fully dilate and see. Now, this is little theoretical, but we should know that for every 1 degree rotation, percentage-wise, astigmatism, there will be 3.3 loss of astigmatic power, cylindrical power. That means if you rotate 30 degree, you are losing the complete cylindrical power. So it is becoming like a monofocal lens. And if you go beyond 30, the cylindrical component will increase. Cylindrical power will increase and patient's distant vision will go down. Patient selection, of course, already we have discussed. Now these are some one. This is case 1, 20 years traumatic cataract. Other eye was 6.6. This vision was 6.24, and the axis was almost vertical. And as you can see, that it was about 42.75 and 46. I've gone too much. And then the CC post-op astigmatism is almost nil. Case 2 is pseudopecia, right? And nuclear sclerosis 3. And then you can see that the astigmatism was about 1.5. And post-op, it is very reasonable, almost nil. Visual acuity has also improved to 6.9. Now, case 3, these are just a few cases I am showing. Surgery, you have already seen from expert. Now, this is total cataract. Total cataract, for beginner, I will not suggest. But not all total cataract are very difficult because you have to see the age factor. This is 37 years. So there won't be hard nucleus. So you can always do. If you can contemplate and if you can complete a beautiful rhexis, there is no problem. And then as you can see, the astigmatic part is corrected post-op. So toric marking and toric lens implantation, I will not go into the details. Operation you have seen, this is what I said. This is HKC technique of marking free of cost. You are getting, marker free of cost. No bubble marker, no joja. You can do it and then put it coaxial. Patient should look straight and then put the slit according to the axis, desired axis, and then it should pass through the center of the cornea. So you target the Purkinje image in the center, in the pupil. So, and once you have given 36 gauge needle, fine scratch, you dry it. Before putting the stain, you have to dry it. Otherwise, the whole stain will be spreaded everywhere. And then this mark you will be confused on the table. So first you make the place dry and then you touch with the marker. This stain remains for pretty long time. So don't worry, on the table, you will have no problem. And then I'm not showing you details of the surgery. Only thing, you put the lens inside and then slowly put it in the bag. The trailing haptic you put in the bag, and then you see where is your toric marking, and then you put it in a way that it is little shorter than your desired. And by the time you have removed all the viscoelastic, you target the final position. You target the final position because removing the viscoelastic, particularly in toric IOL, I think is single most. Even for multifocal or monofocal, little rotation may not have much harmful effect. But toric IOL, you cannot afford to have rotation. If it is rotated, you are losing mark because the astigmatism will not be corrected as desired. After all, it is a premium lens, and after all, your patients are the supreme for you, and you want their full satisfaction, and therefore to get their full satisfaction, to get the wow factor, that the patient should tell everybody that here is a person where after operation I can see even better than my younger age. So that is your success, and that will bring more patients even from Mizoram. People will come to Silchar. So this is actually the arrow I have put only to show you approximately the mark. But for seeing the mark, you have to magnify, because the normal magnification that you are comfortable in operation may not be very comfortably visible marking. So finally to see the marking, you zoom the microscope and see where actually you stand. So once you magnify, you can see better. And then while doing the hydration of the wound, it is better don't overhydrate and don't underhydrate also. Now while putting the lens, of course, that all of you know because it is almost the same. The only thing, the trailing haptics you should put over the optics. And before putting over the optics, you should gently tap the optic down. This many surgeons do not do because they think ultimately it is going through a small tunnel. So what is there in tapping? But it has some importance because if you tap, ultimately it will the lens will come out in the right earnest, the way you want. Because one not properly folded pulsar has shown the haptic was going straight. That is not desired, but he is expert, he can manage. For you and me, this haptic will get distorted, and then you may find it difficult to put it in the right position. So I think it is difficult to give mic to old people because they don't like to leave mic. You should select old people last, so that by the time he speaks, there is no one to hear. Important talk you should finish earlier. So I am again stressing, removing viscoelastic from behind, and don't hesitate to remove viscoelastic from behind. You put the irrigation, I always do bimanual, like Dr. Pal. So bimanual irrigation one, you can jolly well introduce behind, nothing will happen. But some expert even suck the viscoelastic from behind with the suction side also. But beginners, not to venture. Beginner, not to venture. So I think that should be enough. Any point? Anything that I have left about toric? My dear friends, Prabhat, Elcon people, any point I have left?
Everything is covered.
No, you are the motivating factor. I must tell you, because I told you, I was thinking 60 years gone without astigmatism correction. Why toric IOL? But now patients are also happy. I am also happy because I am running my vitreoretina center from the cost of IOL only. I must tell you, VR unit I have started. Himadri came also to IOL, but that unit is running in loss. Thank you. Thanks.
Hello, good evening everybody. First of all, I would just like to take a moment and thank all of you for having me here, especially Dr. R.C. Paul sir and Dr. K.L. Ramsingha sir. Thank you so much for creating this opportunity for me. And I've come all the way from Lucknow to Kolkata. I've been here. And IOL is indeed a cool place with a very warm-hearted people. So very good evening to all of you. I'm here to talk about redefined control in IOL delivery with the new preloaded system. So this is the UltraSert delivery system technology. I'm here to just give you an overview of it. At the tip is the depth guard nozzle, which helps to control insertion depth and is designed to minimize wound stretch in incisions as small as 2.2 millimeters. Following which there is a lens top, which actually protects the IOL during transportation and also while we are injecting OVD into the system. Then there's a plunger lock, which keeps the plunger from contacting the IOL until the OVD has been injected and the device is prepared for the injection. And finally, we have the plunger, which has a spring controlled mechanism and provides exceptionally smooth plunger movement. So why at all do we need a preloaded system is because it causes less of loading error and IOL damage, less post-operative endophthalmitis and less wound damage. Of course, because of the predictable delivery of the IOL into the eye. So here's one video which will demonstrate to you the need for a preloaded system of IOL delivery. This case was running perfectly well until the moment of IOL insertion had to happen. Yeah. So at this very moment, when the IOL has to be injected, this is the traditional conventional manual IOL delivery. It appears as if everything will go just smooth, and now, yeah, there's jerky movement and then a hyphema. Okay, so this is something, this can happen in a perfectly timed, properly done surgery towards the end and land up in a mess. So, and this is another video. Surgery was perfectly done. And then just as we are inserting the IOL, leading haptic gone so far so well. The optic is there, almost there, but then the trailing haptic is missing. Where is it? It's stuck in the plunger, probably, the cartridge. So these are some of the nuances which keep coming up in the conventional manual IOL delivery system. So that's why I'm here to talk about the preloaded system. So there's also a clinical evidence. This is a study published in Dove Press in the year 2018, which actually compares the incision size and intraocular lens performance after implantation with 3 preloaded systems and 1 manual delivery system. So out of the 3 preloaded systems, we see that preloaded system U, which is propagated for UltraCert basically, has the minimum corneal wound enlargement post IOL implantation. So thereby stating that UltraCert insertion can lead to minimum wound damage and minimum corneal wound size enlargement post IOL implantation. So there's another study where it is a retrospective study done which proves that the rate of post-operative endophthalmitis was significantly lower in the injectable IOL group when compared with the forceps inserted foldable IOL group. So, like I told you, there's a lot of unpredictability while we are using manual delivery of IOL insertion. So out of the many issues, some of them have been listed here. So there can be a trapped trailing haptic, a haptic optic adhesion, overriding of the plunger, very commonly we see it, optic edge damage, or the need for additional rotation because of the improperly loaded IOL. But definitely there's a learning curve involved in a preloaded system, and also if there's any lens damage or difficulty because of the learning curve, that you will have to incur. And this is a tutorial video which I would like to just play for you. So these are the various configurations. Here we can see it's a tugged trailing haptic, and this is a loosely looped but not straight. So if it is not straight, the trailing haptic, you can easily go ahead with the IOL implantation. So the plunger should be fully advanced. What they try to propagate is that when we are loading, injection time should be like, you should take 5 seconds to actually inject the IOL into the eye and 7 seconds for the loading. So like what exactly to be done for the loading is, this is the final injection. About 7 seconds should be given for the injection. But before that, This is actually the in vivo loading going on. This is the lens top. Just in front of the lens top is a place where we actually inject the OVD into the lens fill-in chamber. This is the lens fill-in chamber which is filled with the OVD. And the viscoelastic entering into the chamber. This is the lens top which we remove, and now the lens can actually enter into the fill-in chamber. Before that we have to remove the plunger lock also. This is the plunger lock. Take it out. Now the plunger is free to advance. We advance the plunger. It pushes the lens into the lens fill-in chamber. It is popularized as saying it should take at least 7 seconds so that it is properly folded. Now your lens is ready for injection. Now it is a slow but predictable insertion of the IOL. There it is. So these are the different haptic orientations, but any of these orientation is fit for insertion except for the straight trailing haptic. This is the only exception where you have to stop your injection and change the lens probably, right? Then the modification which has recently been done to overcome any shortcomings that previously were there were long tip. Previously it was wound assisted, so there were many complications incurring because of that. So now they've currently made it a long tip, and there's no spring action. Initially, because of the jerky movement of the plunger, there were not so smooth delivery of the IOL, so that's why they came up with no spring action of the plunger, making the delivery more predictable and with lesser of complications. This is a new implant which Alcon is soon planning to launch. It's known as Claron, with its preloaded system is known as Autonomy. It's still in the process, it's in the pipeline. Soon they'll be coming out with it. This is a surgery towards the end. The highlight of this preloaded system is they have a CO2 pump mechanism which actually precisely controls the delivery, more precise. The delivery is more precise and predictable. Similar to the ultrasound system, it also has first you have to give the OVD in the fill-in chamber, then remove the locker. And then there is this speed control lever which needs to be pressed. After the click sound, we press it further to control the speed of the IOL delivery. Yeah. So this was Clarion Autonomy. To be seen soon in the market. Thank you so much. Thank you so much for the lovely evening.
Thank you so much, Dr. Ansari. Now we call upon Dr. Biraj Goswami. His topic will be this year, no mental block. He's going to speak a very important topic.
So, this is a talk which some of you might have heard or seen earlier, and Dr. Rema asked me to go for this talk because I have been using this talk as a motivating talk to inspire the ophthalmic surgeons for a rather neglected subject, that is external DCR, dacryocysto-rhinostomy. I am basically an anterior segment surgeon, but I have continued my passion for lacrimal surgery, and I am rather more known nationally for my lacrimal surgery than my anterior segment surgeries, although I was the first person to start phaco in Northeast. So this is a situation where we have got a huge doctor-patient disparity. We have got so many ophthalmic surgeons, but very few of them are going for dacryocysto-rhinostomy as a whole. As a result, what has happened? There is a huge backlog of this year because the performing surgeons are very less. And this is because of our attitude, our mindset. Attitude is a mindset. Our mind is like a camera. Whatever we see, whatever we perceive, we keep on taking photographs. Something we store, something we delete. Store as memory and something we delete. Is it a magnifying glass? Yes, very much. And as a human nature, we try to magnify the negative things more than the positives. Can it be a binocular? Yes, it can be. If we look at the positives with the binocular, it will come closer, it will be magnified. And reverse the binocular to the negatives, it will go away, recede away, and become minified. And that is required to set your mind positively so that you always see the positive things with the binocular on. After all, perception is a complicated process of whatever we see and whatever we interpret, and it's a dynamic process. It is always better to have a positive mindset because it has a favor of creativity over boredom, joy over sadness, hope over futility, and most importantly, a sense of responsibility over a sense of burden. The most important thing is that we have to realize that we have taken the oath to relieve the patient's suffering, and here is a patient who has come with the problem which is very much in my capability to relieve his or her sufferings. All I need to do is to compose my mindset, that too positively. Fish bones are a common encounter for the non-vegetarian people who relishes fish. For a vegetarian person, it is never an encounter. But he doesn't have the opportunity to taste fish. Similarly, an ophthalmic surgeon will have the complications, but the ophthalmologist not doing the surgery will never have the complication. But he will have the complication of not doing the surgery where the surgery was the only answer. Since Totti described the external dacryocysto-rhinostomy about 115 years back, it has remained the gold standard but still continues to repulse the ophthalmic surgeons. Why? Because it is always termed with a few adjectives. It is fearsome, messy, dangerous, frustrating, and non-productive. Why? The first three adjectives, fearsome, messy, and dangerous, these are because of our ignorance of the surgical anatomy and our reluctance to acquire the refinements. And in short, our reluctance to set our mind positively with a perception to remove the mental block. All these adjectives can be removed with a proper preoperative evaluation, decongestion, knowledge of the operation site, proper preoperative medication, and preferably applying microscope. Because it is the microscope which allows us to see and cut, rather than gaze or feel and cut. Why frustrating? It is because of the failures. This is one important thing where I have got a publication that what are the important causes of failure. These are obstruction in the common canalicular end, granulation tissue or fibrous tissue growth in the flap anastomosis, osteotomy site closure, and sump syndrome. That means the flaps, anastomose flaps will sag. So we can very well remove this adjective, that is frustrating, by learning the procedure, preferably from a master, to identify some conditions which are called scar-prone conditions like acute dacryocystitis, repeated acute dacryocystitis, lacrimal fistula, lacrimal abscess, post-irradiation case like that. We have to create a large ostium that is 14 by 14 or something like that. We have to curate the ostium margin thoroughly to remove the osteophytic activities, because it is always there in a ragged margin. We have to anchor the flaps to the undersurface of the medial pulpary ligament, orbicularis and periosteum, so that there is no sump syndrome. And we have to keep the probe till the suturing ends so that we do not tie up the canaliculus. Always we have to be prepared to give the time what is required. The principal outline, as I say, that incision, the incision is over the anterolacrimal crest. That is the only landmark. And our single stroke should go up to the medial pulpary ligament. You cut it or spare it or partially cut it, that is up to you. But we have to get a good exposure. We have to dissect the sac away from the bone. We'll see the bone, suture, break the suture, go with the punches, progressively bigger punches, make a large ostium. Then cut the flaps. I usually cut the posterior flap. I only stitch up the anterior flap because the outcome is same. And we have to anchor the flaps to the undersurface of the medial pulpary ligament and the periosteum. And keep on chanting the mantra, what I am chanting all these 20 years. This year, the easier, the better. This is a retrospective analysis of my cases for 20 years, up to December 15, where I have analyzed all those cases where I have not used double flap, I have not used any adjunctive, I have not, these are not repeat this year. So total was 3050, not a small number, and out of that 98.42% success rate. When we went for these 42 failures, out of that functional were 4, that means anatomical success was there, but it was functional failure. We did repeat this year in 36 cases and got successful in 34 cases. So total number becomes, total successful number after repeat this year, it becomes 99.81% success. That is almost close to 100%. So when we have got something close to 100%, why we are getting, haunted by that particular adjective of being frustrating? Of course, the microscope is a must, as I see it. And the last adjective in the list, non-productive. Why? It depends on our priority. Whether we are we are interested to earn per minute, or we are interested to relieve our patients. Definitely, choice is yours. We always say that somebody will do it. Somebody has to shoulder the responsibility, but always we are playing the same game. Everybody gets the problem. Anybody can go for a solution of the problem. Somebody will take it, and ultimately nobody takes it. So this particular game is going on because our surgeons are not inspired to take up the surgery. There are certain points which are put in favor of not doing surgery in elderly. All these are blah blah blah. Continued. These are not authenticated, not investigated, and not proved. And so, it is not adequate to prevent DCR above 60 years. I would rather say, why should we take the tragic sight of an old man weeping all the time? Because it leads to a lot of social embarrassment and complexes. And do you think that old man, these complexes and embarrassment is justified for that old man just because he is aged? Rather, there are a lot of advantages like thinned out bone, smaller osteum is adequate, better patient compliance, no fear of dry eye, and failure is accepted better than a younger person. So, we just need the correct and positive mindset and the 4 C's, that is, we have to get a concern for the patient. We have to be committed to our oath that we are here to relieve the patient's suffering. We have to get a confidence in ourselves and get the courage. And again I am telling, the first thing I started, attitude is a mindset. Let us set our minds positively. Thank you so much. Any comment? I am trying very hard to stimulate even one ophthalmologist, ophthalmic surgeon to take up this process. Yes, please. It was a silver lining in the horizon, but it never became a cloud and never rained. Yes, it never rained. It was a silver lining in the horizon. Rather, endoscopy this year has come up with a lot of modifications and improving the success rate quite considerably. And it is the horse in the nosedive with the external DCR. But still then, external DCR is the gold standard. Thank you so much.
Thank you so much, Dr. Goswami. Of course, this year is a very afraid surgery, mainly for this ophthalmologists also. No ophthalmology wants to do this year, because the first thing we face in this year surgery is that bleeding. But these days we have a good control with butterface, isn't it?
Yes, but as I said, do it under microscope, you will have much less bleeding.
Yeah.
Because you will be seeing and cutting rather than guessing and cutting.
Exactly. In those days when there is no microscope is being used, in those days we always face bleeding. It's a real problem during surgery.
Now also, the ICR has
Now
got
also.
a bleeding.
Any question?
Okay then,
Okay.
thank you so much. I will just take one more minute. In Eastern India Zonal Ophthalmic Congress is a platform for all the states of the Eastern Zone, the 5 major states and 7 sisters of Northeast. And we need a good strength in IJOC. Get a membership be into the platform, and as a first step, please come to Kaziranga for the annual conference. It will be a real fun. It's my invitation.
This invitation is from the president himself.
Yeah. I incidentally happen to be the president of IJOC, and sir happens to be an ex-president. Thank you so much.
Thank you, Dr. Goswami. So the last but not the least, may I request Dr. Laura to be in the stage.
Good evening to you all, respected conveners, moderators, our lovely audience who has stayed very late with us, and our amazing speakers. Oh my gosh, I feel so humbled to be sharing the stage with them. And I feel like in retrospect it was a big mistake to call me at the end, because how to keep up with the wow factor. With
To call me last.
See, they should have asked Dr. Chaudhary first.
We had very good discussion.
Yes, we did. I learned a lot.
Hello.
And
You
I
are
think-
the right person to be called at the last.
I think we've learned more than ophthalmology tonight. We've learned a bit of ethics. We've learned philosophy as well from Sir, and we've learned some business tips and tricks from Dr. Chaudhary. I'm gonna take notes. So tonight I'm going to speak about our LASIK journey in Eye Care Center. I feel like it has been such a big pivotal milestone for us in Eye Care Center that we can't miss mentioning LASIK in our anniversary program. I won't take much time. I'll just talk about the facts and figures, and I'll leave the technical part to Dr. Sudeep here. So just a reminder that LASIK is nothing but using laser technology to transform the shape of the cornea. I have a video here, but I think we'll skip that. So the idea of LASIK has always been like a dream for Eye Care Center, and the urgency was realized way back in 2014. Here we can see that a graph was made identifying the different causes for referrals from Mizoram, and we found out that we had a huge number of patients, 330 patients of LASIK referred in just a span of 3 to 4 years. So at the AIOS conference, when Dr. Remsanga went with his team planning to buy an OCT machine, they were captivated with the LASIK program advertisement over there, I guess, and they got persuaded to get this multi-crore machine. I don't know how, but presumably causing many sleepless nights to the missus. And anyway, it was a big step. And for the first time in Mizoram, we have a LASIK center, which was opened in 2015. And it has been supported with the help of Dr. Sudeep Chaudhary here with us tonight. He's been faithfully coming every month, blessing us with his presence. He knows more about Mizoram than a lot of the Mizos out here. He's seen all the best places, tours, which I've never gone to. And he's drawn pictures of it as well. He's a great artist. No wonder he draws beautiful markings on the cornea. Yes, this is the machine, Wavelight 500. And it's aided with the Pentacam technology. So this is the first set of LASIK patients that we had. Then, yes, the bravest people, the forefront. The bravest of them all, yeah. So this is the total number of LASIK patients that we have done so far. 500 females and 393 males. It's very surprising to see that a lot of the males actually they come for less powers. Females usually they have higher powers, but we feel that maybe the males they don't like wearing their specs too much. -1, -2, they do LASIK they are very easy to convince males. So we have 66% of females compared to 44%. And the age group is usually like between 25 to 35 years. This is the age, youngest and oldest. And the powers, usually the moderate powers are the ones who come. Surprisingly, we have less of higher powers, maybe because there are less people with very high powers. So this is the highest power corrected, -13. Actually, this poor fellow, his actual power was very high, round about more than 20, in fact, highest power that I've ever seen personally. So he was having a lot of amblyopia, but he had, I guess, round about 624 vision. Was it 624? Yeah, he was happy. Yes, so this is the youngest patient, and certain times we have to do it, the procedure in younger people when there is asthenopic headaches, or maybe we feel like we can do something for the amblyopia. Yeah, and so this is the first day. On the first day post-op vision, we see that a maximum of the patients have 6/6 vision. Some of the patients have poor visions, but these are actually those amblyopic patients that we take up. So at the end of my presentation, I'd like to show you some of the comments. We maintain a registry of our LASIK patients. We make them write something about their first-hand experience. We don't force anything on them, and these are the comments that they have written. You are all welcome to see the registry if you like. Ending with a beautiful picture drawn by Dr. Sudeep. I told you this is a picture of Mizoram. And with that, I'd like to pave way to the next speaker, Dr. Sudeep. He'll be answering the questions. Yeah.
So I believe it's quite late at night. Sir needs rest also. So please, if anyone has any query or anything to ask or clarify, we'll happily try to do that.
Dr. Sudeep, what is your highest limit of myopia for LASIK?
Sir, it depends on the corneal thickness. So I think that 1999, 2000, we had different machines. We went up to -17 or 18. That time, machines used to cut less cornea for more power removal. Nowadays, the present generation machines, to take around -1, they cut around 12 or 13 microns of tissue. So nowadays, we can at the most reach 10 or 11 at the most. But that time, and surprisingly, most of them are doing quite well, provided that we have kept significant corneal tissue behind.
What is your experience of regression over -8?
Yes, regression is there. Presently, with the present generation machines, the zone, that the area of treatment is higher, so chance of regression is a bit less. And now in the older generation machines, where the nomograms were not that up to date and all those things, so that time we faced regression. But yes, if the regression occurs that time, if you say there were no ORB scan, no pentacam, nothing, and we used to miss on this keratoconus, that undetected ones, the other things which normally now pentacam can pick up. Maybe the regression, a percentage of it may be because of those factors. But yes, it does happen beyond 8. We almost tell all the patients that yes, -1, 1.5 can come in every case.
So do you think that it will be beneficial to make a chart, for regression,
Yes.
increase in regression percentage after -8 progressively, and show it to the patient in your counseling?
Yes, it also depends on age. Younger people has more regression, little elderly group has less. So basically, if we have everything charted out, it's easy to convince a patient.
And do you believe in pediatric LASIK?
I did around 40 in Guwahati, sir, starting from 8 to 10
Yes,
years of
Arundhati
age.
has got a paper.
Yeah,
and
that
she
I
is-
did all the cases.
Yes, Arundhati has
I
got a
did all
paper.
the cases. They presented it in Europe something, but that time the most important challenge was to sedate, how to sedate the 10 years, 8 years kid. So I used to talk too much to the patient, and somehow very fast. The keratomes were easy to use, so somehow we pulled through a few cases, but few requires a bit of sedation. We took patients only of amblyopia and a very high power, plus power, where chance of it rolling back or changing too much is difficult. But otherwise, normal patients we didn't touch.
Do you know that that particular LASIK center is a sister concern for our My Institute? So I have got these things, and pediatric patients regression is quite a high.
Yeah. That's supposed to be high.
Of course, it was done for amblyopia. patients.
Yeah.
Basically, for your person, this 14-year-old, that was an amblyopic person?
So most of them, usually unilateral, both bilateral we didn't touch. We chose unilateral amblyopia where it's difficult. Patient is not cooperative. He cannot put on glass or contact lens. So those type of patients, doctor, they used to select.
For the bilaterals, what is your minimum is?
For
the bilaterals, what is
Oh,
your
yeah,
minimum
yeah.
is?
Sir, I think that 13 or 14 years of age we did.
No. I mean, you without amblyopia, for bilateral myopia.
So normally by convention it's 18.
18.
18 to 19, that's the by convention. Because nowadays we don't take any chance. We explain everything to the patient. Previously when it came, that time there was medias where people tried to venture, and those writing papers, books and all. So that's why you get courageous, you lose many times you end up in making mistakes, you realize later, correct yourself. That's the way probably to look at it.
Thank you.
Thanks so much, sir. Good night. Anyhow, people are very sleepy. And last part is that we have anything, sir, we have to the closing.
Okay, thank you very much for your patience. So we are closing our scientific session. The CME credit hour is 1 point. Nowadays here in our state, a clinical establishment act has been introduced. So MCI also is going to be very strict. So, but we are still lucky to have a principal director also witnessing our activities. So, shall we close our program with distribution of our certificate? Thank you once again, all the guest speakers, for coming a long way to Aizawl. So, thank you also all the participants for your patient hearing. So may I call upon Dr. Ruata, is the Vice President of our Ashom, Ophthalmic Society of Mizoram. We just have started. Yeah, he will give away our certificates.
May I request Dr. Mingi to read it out for me?
Okay. Do you think she can read it?
Yeah.
This is the treasurer of Ophthalmic Society
yes.
of Mizoram. Okay. She has a good eye.
And
Yeah.
Dr. Mami was talking about this medical ethics. Not like an ophthalmologist, but she's from IMA. And I'm also the Vice President of Mizoram Medical Council. So that the first part of our talk was, so to say, unless we talk that one, you cannot get that this certificate. Yeah. Okay?
We all belong to IML.
Yeah. No.
We all belong to Indian.
Oh, yes. Okay.
Yes,
Come.
Dr. Lalian Lira.
Thank you, sir. You are with us. Oh, you got 2 points. Yes. Cesar.
Dr. R.C. Paul. 2 points. Dr. H.K. Chowdhury. I think it's 2 points.
Somebody take
Yeah, 2 points.
Oh,
with my all teacher.
okay. Please.
Please, somebody. He was a classmate of Dr. Sang Loya, our senior most ophthalmologist from Mizoram. He taught us something.
He told us something.
Not analytical.
Only ethical. Dr. Biraj Joyati Goswami. You are getting 2 credit R. Dr. Sudeep Chowdhury. You are getting 2 credit R.
It's the first time ever I am receiving a certificate.
Dr. Nadeem Ansari.
Dr. Ansari,
2 credit R. Dr. Lalbuthangi Mar. You are awarded 2 credit R.
very lucky.
Dr. Laura Virthangi, awarded 2 credit R. Dr. Lalbuthangi, 1 credit R.
Only one.
Dr. Siren Lian Silo, 1 credit R. Dr. Mac Masopanga, 1 credit R. Dr. Vanna Troy, only the speakers are getting to us. Dr. Lan Tua Marani, say how. Dr. Sira Dukimi, Dr. Mary Ilan Sandami, so Sarabnam Aimol, CH Tigobi, CH, is it CH? CH or Cho?
Charity,
Ferdous Jaman, Raktim Das, Dr. Panel Ruata,
Dr. Alvin Moy.
thank you.
Finally, I would like to announce tomorrow there will be a live surgery of LASIK and cataract with panoptics. So you are all requested to come and see in our center. Good night, everybody. Thank you. Thank you all.